Legend. Sweet, you can hear me, Louis?
Yep, I can hear you.
Legend, dude. Bro, welcome. Today we're just going to quickly go through some updates in relation to paediatric mild and moderate head injury. Today we're in the hallway. You flicked me a PDF. I haven't seen it before, and we're going to go through it. I guess some things we're going to talk about is just for a bit of flow, what we used to do,
Yep.
and what's changed, and we're going to run through a flow chart.
Yep.
This is new.
Yes, it is new. As of June this year, I think it was published by, led by, it's a multidisciplinary team, but it's led by emergency department at Royal Children's Hospital in Melbourne.
Awesome. So this is pretty fresh.
But yeah, as you know,
Yep.
mixed ED or pediatric EDs have a lot of kids with head injury.
Okay.
Luckily, a lot of them are minor,
Yep.
but sometimes you've got those that are seemingly minor with clinically significant head injuries.
Okay.
The issue is, and it's almost always the minor to moderate injury that you need to worry about.
Yep. Mild to moderate.
As you know, the severe, they're sick, they need something done.
Yes.
They need to be transferred out or go to neurosurge. Moderate, easier, is even easier than the mild. The mild's in a lot of gray zone. Luckily, there's not a lot of clinically indicated significant mild head injury patients that need something done to them.
Good.
We have to be aware these are kids.
Yep.
And to image them have significant future implications with
Yes.
lethal malignancies.
Yes.
I think 1 in 1,000
Okay.
gets some lethal malignancies.
More than likely from CT brains.
Exactly right.
Yep. Okay.
Even though that carries, as we were talking to before, I think about in current high-res CTs, I think it's one single shot of CT head is equivalent to, what did I say? 8 months of background radiation, as opposed to CT chest, which is 2 years.
Yep.
But an X-ray is only 10 days of
Yep.
background radiation.
Yep.
So if we can avoid it, and if your institution allows for observation, by all means, go for it. But
Yep.
essentially, the new algorithm puts the onus, or has a lot of clinicians have a lot of say.
Yeah,
because they're there, they can look at the patient
Yeah.
and decide what's best.
Yeah, because algorithms are great because they're helpful for us to follow a flow.
Yeah.
But technically, as clinicians, we do our studies so that we can examine a child and decide, in the best interest of the child, are they safe to go home or should we stay home?
Exactly.
Should we stay in hospital? And the next thing is, should we image them or shouldn't we image them? I guess there's a lot of...
Again, it depends on the parents, parental concerns.
Yes.
If they've got it in their head that their child's getting a CT while they're getting through the door.
Yep.
Sometimes it's hard to dissuade that.
Yep.
Then again, the past clinical decision rules.
Yep.
Tell me a toddler, that doesn't have repetitive questioning.
Yeah.
Is not agitated in the middle of the night.
Yeah.
Or is not vomiting anyway.
Yeah.
Even if they don't have a head injury.
Yeah, 100%.
And that counts for 1 point in some of the old clinical decisions.
Yeah. So what did we used to do? Let's say a child has come in, I'm always stuck on this 4-hour rule. Normally kids come in and they say 4 hours of examination from onset of head injury, we keep them in hospital.
Yeah.
What did we used to do and what's different, I guess?
In the past, 4 hours, yeah. In the past, there has been clinical decision rules, mostly based in Canada or North America.
Yep.
The Catch 2, which usually tends to rule in the child that requires a CT scan.
Yep.
And then the PCAN is the opposite.
Yep.
And that excludes those children that have mild head injury that do not need hospital beds or any period of observation, basically people that you can discharge home safely.
Okay, all right.
But in America, North America, they tend to CT scan these kids more than we do here in Australia and New Zealand.
Yep.
So I think their CT scan rate is over 10%, whereas ours is closer to 2-3%.
Okay, so we're pretty low. We have a low threshold not to CT, where they have a high, lower threshold to CT.
To CT, and you're talking about kids that 1 in 100 kids might have CT abnormality.
Yep.
And 1 in 200 of those will have clinically indicated significant brain injury. Okay. So it's not that much for what you're scanning.
Yes.
Yeah.
Cool. Run us through this this flow sheet. So you're working in ED. We've sent out a new flow sheet.
Yep.
A child comes into ED. Run us through what we do.
So you just alluded to the 4-hour rule.
Yep.
So this is you can use this up to 72 hours.
Okay.
Now, acute injuries that happened minutes ago, if kids have symptoms up to 72 hours, it's included.
Cool.
Because they're significant.
Yep.
If you still have symptoms, you get included.
Okay, good.
And like I said before, again, there's a lot of clinician-based decision,
Yep.
which is very important in this.
Yep.
I'll see if I can do the.
We'll zoom into it.
So, as said here, within 72 hours of head injury,
Yep.
this is all inclusive of kids that are less than 18 years old, so pediatrics less than 18,
Yep.
specific to Australian and New Zealand standards. And there is an exit pathway already,
Yes.
and basically those that you are suspected of non-accidental injury,
Yep.
kids with pre-existing neurodevelopmental disorders
Yep.
and VP shunts
Okay.
and bleeding disorders. Things that would make you CT them a lot less with a lot less stringent qualifiers. Basically.
Yes. Okay.
So they exit. They don't get into this.
No, they're not in this study. We're probably more than likely going to CT those kids anyway because we're concerned.
And
Yep.
again, you
And under
exit-
6 month old as well.
Yep, that's right. Yep.
Cool.
Yep.
Interesting. Cool.
And you exit again if based on GCS.
Okay.
So 13 or under, you straight to a senior clinician observation
Yep.
versus a CT. That's straight away.
And they're using GCS as the level
Yeah.
of functioning still as a score.
Which is hard because you have those. You've got the pre-verbal kids. That are
Yeah, you
listening
do.
to.
Yep.
So I think with those ones you'll still use AVP.
Yeah. Yep.
Whatever you use in
Cool.
your institution.
Yep.
And then once you classify the mild to moderate, which is
Yep.
GCS 14, 15.
So we've got a kid who's GCS 14 to 15.
Yep.
They haven't got any of those risk factors we talked about: alcohol, under 6 months, no VP shunts, no bleeding, neurological neurodevelopmental issues, and no abuse that we're thinking of. We go down this green pathway and we assess for what's next.
Then you assess for clinical initial observations and clinical signs and symptoms,
Okay.
basically. And this is all that's been regurgitated in the past. It's things that are, the depressed skull fractures or the bogginess.
Yep.
That's significant. And significant ones are those that are non-frontal.
Yep.
So frontal bone, as you know, has got two tables, the outer table and the inner table. Less likely to have a brain injury underneath that.
Okay.
So non-frontal hematomas, on the other hand, significant because they're usually the brittle part of the scalarium. More than that, if it's along a suture line, again, that's more significant of a head injury because that's, again, it's...
Likely to pull apart there.
Yeah.
Yep.
And you have issues with meningeal herniation in later on in life. If you've got a palpable skull fracture, of course, and you've got LOC of more than 5 seconds, and parents are concerned. If the parents are concerned, they know this child well. If
Yes.
they're concerned, it should trigger red flags.
Yeah, it's true.
Again, they're over 2 years old, easier to sort of get a history from. Same kind of thing, loss of consciousness, signs of skull fractures, like the raccoon eyes.
Yes.
Fluid coming out of the ears,
Yep,
otorrhea, rhinorrhea, or CSF rhinorrhea,
Yep.
and severe headache.
Yep.
Those are, then you classify them into intermediate, high or low risk.
Okay. Is vomiting still one of those things they pick up? They're still
Yeah.
talking about vomiting being huge. Yeah, cool.
Definitely, but this time it's vomiting more than 4 hours. Vomiting 4 times or more.
More. Okay, cool.
And this is not vomit, and
No,
nothing. This is a vomit, 15 minutes or more, then another vomit.
Okay, that's important, isn't it?
Yeah.
Because we still have that kid that's vomiting, but he's just gone "Ugh," and waited, "Ugh, ugh, ugh," and then it's like, oh, he's vomited 6 times, but he's just
a puker.
yeah, he's just still puking his first vomit.
Yeah,
he's
there are kids that are vomiters and pukers.
yes,
There are kids that just don't vomit at all.
yeah, it's so true. Eh? Some of them don't, but that's important.
And you treat them with ondansetron, whatever you do. But
cool.
if they've got a clinically significant head injury, they will still vomit despite ondansetron. as
Yes,
you know.
yeah, that's true. We're not masking it by giving you a dance. No,
just
cool.
like this myth that people have. Oh, I don't want to mask anything.
Yeah, I won't take the Panadol because you won't be able to assess the leg. Like, come on, yeah, as if.
Yeah, and then once you go down to that, it's more self-explanatory, more than 2 risk factors, and they have seizures or persistent headache, significant vomiting, even after 4 hours, then you definitely get, here, the big common denominator is senior clinician review.
Cool.
They can decide whether you actually have room for observation or
Yes.
time,
Yep.
or they need an urgent CT.
And so I guess for junior-ish clinicians, if they're falling into the intermediate to high risk, they're really early getting a senior doctor to look at them, to examine them to see if they need a CT.
Make early
Yep.
decision makers, basically.
Yep. So if we were to categorise low, intermediate and high, the lower risk ones are GCS 15 generally,
Yeah.
aren't vomiting.
Yeah, and no red flags.
Yep.
Or vomiting for not more than 4 times. Or
Yep. Okay.
No red flags and normal mentation
Yep.
with very uninteresting mechanisms.
Yes, cool. Yep. And then those kids generally will be head injury advice.
Yeah.
Watch them in the ED for a bit to make sure they're good and then send them home.
And with if the parents are not concerned and
Yep.
parents are happy with the
Yep.
plan B or plan A. Yeah.
Yep. So talk me through the intermediate. We've got an intermediate person who meets one of the risk factors.
Yeah.
A senior doctor looks at them. What are you thinking of when you go and look at a kid who's got a mild to moderate head injury as a clinician?
Yeah, it's funny. I'm a big believer in Gestalt. I guess I've been around long enough
Yeah.
to be worried by a person that I'm worried for.
Yes.
So I'm looking for things that trigger my spider sense, I guess.
Yeah, cool.
So
What things trigger Lewis's spider sense in kids with head injury?
Concerned parents.
Yeah.
Kids that are flat.
Yes.
And then vomiting.
Yep.
But if they've got signs of significant head injury, and
Yep.
that's again, the non-frontal thing is very big. Occipital and temporal head injury, even though they're mild, they tend to have an underlying skull fracture.
Okay.
Which again might not need anything.
No.
But that'll make me observe them a bit longer.
Yeah.
Basically.
Okay. Yeah.
But yeah, it's the child that's not behaving like they should.
Yeah. Do you ask parents that? Is your
Yeah.
child normally behaving like this?
Yeah.
Do they normally behave like this? Yeah.
And but then again, they don't know the risks of the CT.
Yeah.
So then I have to do an informed consent that this is
Okay.
what the risks are.
Yep.
If it was my child, I
Yep.
usually go to that
Okay.
effort. I wouldn't go CT because the risk benefit reward is
Yeah.
not warranted.
Yep.
So I often tend to observe more than
Yeah.
I scan. I can count in my hand how many kids I've scanned.
Yeah. That's
And
interesting.
even
isn't
if
it?
they're positive, they didn't need any intervention, and they
Yep.
got discharged the same day from
Yep.
the draining hospital that we referred to.
That's good, isn't it?
Yeah.
I guess it's the high risk ones, like you said, they're kind of
Straightforward,
easier, aren't they? Like
Yeah.
you got a kid who's a GCS 13,
Yeah.
you're going to go through the scan and more than likely, you know what I mean?
Yeah.
It's the intermediate to low, which are the ones that we get a bit, confused with, I think. And anything you changed in terms of, you said there's a lot of emphasis on senior clinician review, even at the start when there's a red flag immediately, you're getting asked for someone to have a look at it from a senior perspective.
I think we'll scan less and less with this algorithm,
Yep.
which is refreshing. With the old PCARN and catch, you tend to be scanning a lot of lower risk patients, because they'll have a risk factor or two,
Yep.
but that puts you in the scanning category
Yes.
as opposed to observation.
Yep.
So it's good to see because we certainly don't follow the North Americans in terms of trigger happy for scanning.
Do you think this is safer from your perspective?
Safer, we'll see.
So-
But I think
Yeah.
given the odds of clinically significant head injury is very, 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 very low,
Yep.
I think it's safe.
Cool. And how do people find this article if they're looking it up and they're working in hospitals?
Yeah, you just type in I predict head injury.
Yep.
It'll come in. The actual document is 256 pages long.
Cool. And we're on what page are we on?
No, this is just
Oh,
the
we've got
algorithm.
we've got the algorithm.
But
I'll put it up
can
in
get
the bottom of the
summary,
notes, yep.
which is only 18 pages. But
Cool. I think we'll get the summary. I don't think I've got 287 pages in me, mate. That's awesome. Cool.
Yeah.
And just quickly, do you regularly get asked to look at kids with head injuries?
I
Same
tend to, yeah.
Yeah.
I actually tend to pick them out of the waiting list
Yes.
because in the end I know I have to make a decision on them.
Cool.
So unfortunately for the GMOs, they don't get to learn.
Yep.
But I take them out of the queue and get them sorted.
Yeah.
earlier.
So at least you've examined them
Yeah.
first and you said,
Yeah.
they're going to be waiting for 3 hours. At least I can
Yeah.
examine them at an hour and a half quickly.
Exactly. And I'll know
An
if
hour.
I need to call retriever
Yeah.
early or neurosurgeons early
Yeah.
versus just getting the pediatricians involved for observation.
Just quickly with the spider sense thing, do you think that's something that you learn as a clinician to be like, I'm worried and I
Yeah, I think
feel like
so.
I should do it, I'm going to do it? Or
I
what?
think it comes with. I mean, it gets more and more refined the more senior you are.
Yep.
I think.
Be like Yoda.
observation you must do.
That's so good. Scanning. So that's an in-joke between me and Louis. But yeah. But you know what I mean? You get...
I agree. I think it gets refined as the more things you see. And again, I'm nothing compared to somebody that just works in purely pediatric.
Yes, you're a mixed emergency department. Yeah.
So they'll even have an even more attuned sort of radar.
Yeah. And do you like someone when they're telling you if they're coming to exam, like here that you examine, do you like them to tell you what's going on, or do you like to examine them first and...
Preferably, I'll get the kids to tell me what's going on.
If they can.
Verbal,
Yeah, cool, awesome.
And again, following this, there are, for those that you're going to discharge that you're concerned, essentially they're repeat offenders in terms of head injuries. There are tests that can predict prolonged concussion syndromes, like tandem stance testing and all that stuff.
Yeah.
If they fail on those, they're likely to have
some of these things.
Yep.
And I guess it's important to examine them early with our GCS pupils, limb responses, and examine the head, neck, skull, back, for other mechanisms of injury as well. Cool. Thanks, Louis.
No, thanks, Ben.
You.